Everyone, and thank you for joining us today live on YouTube. My name is Vikram Rajan. I'm a senior health specialist for the World Bank, and I'll be your MC for today. The World Bank team that works on this knowledge series includes Kevin Yunil Kim, Caitlin Jason Yu, Aram Han, and Akasua Dakwa. Before we get started, I would like to mention that the chat function is active in the YouTube live stream. Please send in questions and comments about the presentations and the panel discussion. We will try to answer them live if time permits. I will get back to you via email. For our colleagues from Europe, Africa, and parts of Asia who may not be able to join us today due to the time differences, we will be recording this session and putting this on our website. We're happy to follow up with you in case there are any further questions on this. Today is the first in a webinar series for COVID-19 preparedness and response. This event is jointly organized by the World Bank Group Korea Office, the Health, Nutrition and Population Global Practice, and with generous support from the Ministry of Economy and Finance from the Government of Korea. The COVID-19 pandemic has had a detrimental impact that is globally, that's pushed millions of people into poverty and also sent economies into recession. Although the East Asia and the Pacific region was one of the first regions to be affected by this, they also responded very quickly to the pandemic. Several EAP countries have received World Bank Group policy advice as well as financing, and helping them respond not just to the pandemic, but broader human development challenges that have come from it. Also, along with governments, many relevant experiences and lessons on COVID-19 preparedness and response have emerged from the region, which are useful not just to share within the East Asian Pacific region, but with other countries globally. The region is also focused on resilient recovery to mitigate the socioeconomic challenges from the pandemic and build back better through innovation and climate-friendly approaches. In this particular knowledge series, we seek to share preparedness and response lessons from 5 countries in the region: Korea, Mongolia, Malaysia, Vietnam, and Fiji. There are a broad variety of countries in this region. We want this to be representative as much to the extent possible of the region. This particular webinar series today will begin with experts from Korea and Mongolia who will share their key findings from their country case studies. A panelist of experts will then reflect on the lessons learned and how these lessons can inform other countries to help them develop responses to not just COVID, but any future pandemics as well. We hope to have 2 more webinar series in a couple of months interval, covering then Malaysia, Vietnam, and Fiji. We very much hope that all of you can join us for those webinars as well. Today we have a full agenda. We start this webinar from hearing from Junho Shin to welcome today's guests and participants, and who's the director of from the Korea Ministry of Economic and Finance. This will be followed by Daniel Dulitsky, who's a regional director for the Human Development East Asia Pacific region of the World Bank Group, who will provide us updates on global updates on vaccines. We will then hear from our first presenter, Dr. Taijin Lee from the Seoul National University, who will take us from COVID updates and lessons learned from Korea. Then Dr. Tumabat Byamba from Anagak Ukani Mergachild Nudin Academy, who will talk about Mongolia. Then we are going to hopefully have an exciting panel discussion who will be moderated by Aparna Somanathan, who's the HMP practice manager for East Asia from the World Bank. And we have with us today Dr. Sunman Kwon from Korea, Dr. Uchirbat Batbayar from Mongolia, as well as Dr. Gabriel Leung from Hong Kong, who will be part of the panel discussion. Lastly, we will hear from Jason Alford from the World Bank Korea office, who is a special representative and the country manager of the World Bank Korea office, will be wrapping up today's webinar and sharing his closing remarks. Without further ado, let me hand over to the Director of Development Finance Bureau at the Ministry of Economy and Finance of Korea to deliver the opening remarks. Over to you, Director Jun Ho-shin.
Thank you. Good morning. My name is Jun Ho-shin, Director of the Development Finance Division at the Ministry of Economy and Finance of Korea. First of all, I would like to welcome our distinguished speakers, panelists, and online participants joining the launch of this webinar series on the World Bank Group Korea Partnership on COVID-19 Preparedness and Response. I would also like to express my gratitude to Special Representative Jason Alford and the Korea office team, as well as Health Global Practice of the bank for organizing this excellent event. Distinguished guests, as you are all aware, it has been 2 years since the start of COVID-19, and we are now at a staggering 509 million confirmed cases with over 6.2 million deaths around the world. Moreover, new variants have now taken center stage and are affecting both the public health system and the economies of many countries who are still struggling with the pandemic. Korea is not an exception. Korea has also experienced the hardship and learned some important lessons. These lessons will be shared in more detail by today's presenters. Taking this opportunity, I would like to emphasize one recommendation and one suggestion to our partner countries and the bank staff in dealing with possible future pandemics. First, enhancing early engagement and strengthening coordination among partners are a key element to being ready for the pandemic or another type of similar crisis. We need to intervene systematically at an early stage and have fiscal policy buffers to respond immediately to prevent any loss of lives and economic development. We also need to work closely with international and regional development partners to solve bottleneck problems and mobilize long-term financing for providing resources. Second, during this whole process, the Korean government is ready to support other nations strengthening their preparedness and response based on its various financial channels that can work with the World Bank. In line with that, the Korean government and the World Bank agreed on the vision to make the Korea office into a hub for innovation and technology for sustainable development in 2019. We also established various trust funds in the bank to provide grant support on sustainable development of member countries. The Korea World Bank Partnership Facility and the Korea Green Growth Trust Fund are good examples of flagship funds that can support not only preparedness against health crisis, but also long-term sustainable development and resilient green recovery, etc. I want to conclude by mentioning that as we work together to end this pandemic, we must draw on the lessons from many countries such as Korea and Mongolia to help prepare the world for the next global health emergency. As many countries shift towards living with COVID-19, it is very timely for this project to reflect on the best practices, challenges, and practical approaches. I look forward to today's presentations as well as the insights of our esteemed panelists. Thank you.
Thank you very much, Director Shen, for those remarks. I think you make the very important point of being collaborative in this approach, and we very much would like to thank the support or your support for this program of also enhancing knowledge and lessons learned on dealing with pandemic preparedness and response. So thank you very much. And now I would like to welcome the World Bank's Regional Director for Human Development for the EAP region to deliver his remarks. Daniel Dulitsky, over to you.
Thank you, Vikram. I would like to welcome everyone and thank you for being here with us this morning, Asia time. My name is Daniel Dulitsky. I am the Regional Director for Human Development for East Asia and the Pacific at the World Bank and oversee health, education, and social protection and jobs programs in the region. One of our goals is to ensure that World Bank regional and country activities in human development are informed by global strategies while being focused on supporting country-specific challenges. A key component of that is to foster knowledge exchange and support innovation through our analytical work, policy dialogue, and lending operations. I am glad to find all of you joining the launch of one of our key knowledge exchange activities today, which is the first of a series of such exchanges. We would like to thank the Ministry of Economy and Finance, Republic of Korea, for their support in this endeavor, as well as all participating countries. As we all know, COVID-19 has been with us for more than 2 years, and it has been rapidly evolving, as well as the country's response to it. Initially, countries focused on travel restrictions and border controls and the enforcement of public health measures on COVID-appropriate behavior. This was followed by a test, trace, isolate, and treat strategy. And most recently, the emphasis has shifted to vaccinations and genomic sequencing. The advent of the Omicron variant has changed the landscape of the pandemic response and reaffirmed the importance of vaccination. Omicron was comparatively less severe than other variants, but this may not be the last variant, and the next one may be milder or more severe. Many studies show that vaccines and prior infection elicit strong and lasting immune responses. Vaccines are doing exactly what they were developed to do: prevent serious illness and deaths, not infection. Vaccines, reinforced by boosters and widespread natural infection, will build strong immunity to protect from future variants. Hence, having strong vaccination programs is necessary for managing COVID-19 as an endemic disease in the near future. However, vaccines are not available in all regions equally. While the high-income countries have fully vaccinated more than 72% of their population, low and middle-income countries have vaccinated about 35%, and only about 6% of the population has been vaccinated in low-income countries. Globally, more than 10 billion doses have been administered, but less than 1% have been administered in the low-income countries, where 8.4% of the world's population lives. Among all regions, most of the challenge is concentrated in sub-Saharan Africa. The World Bank followed a multi-pronged strategy of support, which included, among others, financing, country diagnostics, convening stakeholders, facilitating contract management, and making strategic investments to build production capacity. As of February of this year, 69 countries are benefiting from World Bank-financed COVID-19 vaccine operations across all regions, with more than half of those projects operating in Africa. Total commitments are over $7.5 billion. All low-income countries have projects. The bank approved projects have purchased 504 million doses of vaccines, of which 207 million have been delivered and 156 million have been administered. The bank is also financing projects for emergency COVID-19 response, health system strengthening, community engagement and risk communication, and social and financial support to households, to name a few. Total commitments to COVID-19 response stands at $11.6 billion. In East Asia and the Pacific, our total commitments are about $2 billion, out of which $1.5 billion are committed to COVID-19 vaccination programs. The bank also works through partnerships at all levels, including governments, other development banks, international organizations, development partners, foundations, and the private sector. We recognize that the COVID-19 pandemic has had broader effects beyond the health and clinical impacts, including slower economic growth, increasing poverty, learning losses, and increased unemployment, all of which have deep implications for building human capital globally. Unfortunately, we know that COVID will not be the last pandemic. The risk of future pandemics is actually increasing. Hence, the World Bank will continue supporting countries to build resilient systems that will prevent, prepare, and respond to future pandemics. With that in mind, I look forward to hearing from Korea and Mongolia about their experiences and lessons today, and also from other countries in the region in the next webinars. I hope this informative session will strengthen our understanding of pandemic responses and help us to better prepare for future pandemics. Thank you, and I hope you will enjoy the webinar today.
Thank you very much, Daniel, for those remarks and giving us a global overview of what's taken place in terms of the bank response, as well as how we look forward to this knowledge collaboration amongst different countries. Now, without much further ado, I would like to welcome our first presenter. Dr. Tae-Jin Lee is a professor of health economics at the Graduate School of Public Health at Seoul National University. His research area includes economic analysis of healthcare systems, especially focusing on health financing and financial protection, as well as economic evaluation of various interventions in the healthcare sector. He has also served as an advisor to the Korean government in health policy and is currently a member of the Pharmaceutical Benefit Advisory Committee for the Korean Ministry of Health and Welfare. Dr. Lee, thank you for joining us, and over to you for the presentation.
Okay, thank you, Vikram, for your kind introduction. And hello, everyone. I am Tae-Jin Lee. I am very honored to have the opportunity to make a presentation on Korea case study on COVID-19 preparedness and response. Let me share my slides with you. I cannot share my slides. Amy, please allow me to share my slides. Okay. Let me get started. Next, please. Yeah, this slide shows the table of contents of the Korean the country case study. My presentation will follow the order of this table of contents. Next, please. Okay, let me briefly summarize the epidemiology of COVID-19 with some important government measures. The first COVID-19 case in South Korea was confirmed on January 20, 2020. Next, please. Due to the local outbreak in Daegu-gyeongbuk area in February, the number of daily confirmed cases rapidly increased, exceeding 10 per million. During that period, the government announced the social distancing policy instead of a draconian lockdown. In the early phase of the outbreak, the stringent government measures, including social distancing policy, was successful in reducing the number of new confirmed cases and deaths. However, the number has continued to increase throughout the pandemic. The gradual return to normal was implemented from November the 1st last year, although the number the number of daily confirmed cases increased to 50 per million in October. The recent outbreak of Omicron variant dwarfed the previous waves, with the number of daily confirmed cases reaching almost 8,000 per million in March this year, which is the world record, I think. Next, please. If you look at the number of cumulative deaths among OECD countries as of April 19, the total deaths per million were 420 in South Korea, which is the second lowest to Japan. And South Korea's case fatality rate was as low as 0.13%, which is similar to Australia. Next. Turning to socioeconomic impact of COVID-19, the social distancing policy enabled continuous production of activities and business cycle with support of relief funds. Like other advanced countries, the Korean government's fiscal policy has kept an expansionary stance to cushion the economic effects of the pandemic. Next, please. Okay, so the Korea's economic contraction in 2020 was smaller than in most OECD countries, with the real GDP declining by 1%. This graph shows the total number of deaths and GDP growth in 2021. So we can see that the South Korea was doing relatively well in both terms compared to other countries. Next, please. The economic activity, particularly export of high-tech products, recovered shortly after the second quarter of 2020. However, the private consumption in gray line continues struggling across the year. Therefore, emergency disaster relief funds and customized economic supports have been provided several times since the outbreak of the pandemic. Next, please. And now let's turn to preparedness. First, disease control mechanism. Korea's national infectious disease risk alert system has 4 levels of crisis alert. This figure shows the response system of Korean government when the level of alert is highest. As you can see here, the Central Disaster and Safety Countermeasure Headquarters, headed by the Prime Minister, makes the final decisions, while the Korean Disease Control and Prevention Agency, KDCA, actually the former CDC, provides the key technical information to those decisions. Next, please. Okay, legal framework and policy measures. Korea has the Infectious Disease Control and Prevention Act, which is the primary law to prevent, respond to, monitor, and evaluate infectious diseases in Korea. And the IDCPA has designated specific roles and responsibilities to government bodies since the Merck outbreak in 2015. The IDCPA was updated several times during the COVID-19 pandemic to facilitate flexible response, including data collection from various sources and information disclosure to the public. Next, please. Preparedness in terms of health system. As you know, Korea has national health insurance as the major financing mechanism for healthcare. So there was no financial burden on patients for the tests and treatment of COVID-19 as they were exempt from co-payments for communicable diseases. Let me tell you a little bit about telemedicine. Telemedicine has not been introduced in Korea prior to the pandemic of COVID-19, mainly due to the opposition of the Korean Medical Association. However, the telemedicine was temporarily allowed to improve access to care and reduce potential cross-infection during outpatient visit. So the telemedicine service has been covered by the NHI throughout the pandemic. Next, please. Okay, now let's turn to response in terms of testing, tracing, treating, and vaccinating. Korea has relied heavily on extensive testing and contact tracing combined with social distancing from the beginning of the pandemic. In contrast, Korea was lagging in vaccination, which started in late February 2021. It was delayed due to intermittent shortage of vaccine supply, due to late contact with vaccine manufacturers in an early stage of vaccine rollout. Despite the delayed start of vaccination, as of April 19 this year, almost 90% of people in South Korea were fully vaccinated and 65% had a booster shot. So due to the vaccination strategy that prioritized the protection of high-risk groups and the social distancing policy, South Korea has been able to minimize the demand for intensive care, infection transmission, and death toll. Next, please. Next, please. Okay. Patient triage and service delivery. In case of an outbreak of the pandemic, it's very important to reduce the burden on a health system, which is closely related with the case fatality rate. So facing with rapidly increasing confirmed case, on March the 1st, 2020, the government published a guideline to classify confirmed cases into 4 categories: mild, moderate, severe, and very severe. Moderate to very severe patients were hospitalized and assigned to negative pressure isolation room if necessary, while mild patients were monitored in living treatment centers. In living treatment centers, medical providers stay there and check the vital signs twice a day to transfer patients to hospitals if their symptoms get worsened. The patient classification system with living treatment centers was able to alleviate the burden of acute hospitals during the pandemic crisis to a great extent. Next, please. Next. Okay, this communication. Since January 2020, Korean central and local governments have taken various measures to disclose real-time information to alert individuals to a risk of viral transmission, as well as inform them how to reduce the risk. Three types of information have been disseminated to the public on a daily basis. Diagnostic information such as daily and cumulative numbers of newly tested, diagnosed, expired persons. Prognostic information such as detailed information of how to get COVID-19 test, treatment, and vaccination. And policy-related information such as levels and rules of social distancing measures and related recommendations. Next, please. Okay, ICTs. An integrated ICT-based network centered on KCDC developed to establish real-time information sharing system. We have actually a long list of ICT applied to contact tracing, including self-diagnosis mobile application. I'm not gonna go into details of them for the sake of time. Let me tell you one thing about public mask purchasing system, which was implemented through the drug utilization review system of the NHI, which gave on-the-spot information on one's purchasing history at any pharmacy. So it contributed a lot to controlling the demand for masks when there was a shortage of supply. Next. Another example of innovation is drive-through screening system, which was introduced to manage the risk of cross-infection. Next, please. Okay, social protection and disaster relief funds. The prolonged COVID-19 pandemic worsened the economic situation of many households and small businesses. So as shown in this table, disaster relief funds were provided several times to protect the most economically afflicted. The first relief fund was organized for the entire population, while the later three disaster relief funds were targeted to certain businesses, occupations of vulnerable populations, especially small businesses and insecure workers. Next, please. Okay, UHC. Now, next, please. I'm going to skip this one. Okay, the social distancing policy and the redistribution of medical resources due to COVID-19 may have caused decrease in medical access and unmet needs in essential services. So this slide shows the impact of COVID-19 on health expenditures of the NHI in 2020 by type of medical institution and by the Department of Ambulatory Services. So the increase rate shown in yellow line of health expenditure in 2020 was much lower than the average growth rate over the previous decade, shown in gray line. And the impact varied depending on the clinical department, showing a sharp decrease in utilization of pediatrics and ENT by about 36% and 20% respectively. And a large increase in the utilization of psychiatry by 19%. Next, please. Yeah. Okay. On the other hand, a decrease in medical use does not necessarily mean a decrease in the quality of medical services or level of population health. This may be particularly true of Korea, where the average number of outpatient visit was too high, over 18 cases per person per year. So it's necessary to find out whether significant decreases in medical use in some patient groups has actually had negative effects on their health. Okay. Lastly, lessons learned. What's the best practice from Korea? A centralized control tower and coordination system between central and local governments were prepared from the previous experiences. The second, the rapid response should be supported by the revisability of the legal framework. For example, facing the criticism on privacy issues, Korea had the IDCPA law revised immediately to reduce the scope of information disclosure while maintaining some essential information for contact tracing. And third point is the ICT innovations contributed to alleviating the burden on testing and tracing, operating living treatment centers, and supplies procurement. And fourth, the patient classification system along with the designation of living treatment centers helped tremendously to reduce the burden on hospital facilities. Next, please. What are the challenges? Infodemic has put the policy measures at the risk of public mistrust and misinformation. However, at an early stage of vaccination, its side effects were exaggerated by some media and politicians to a great extent. So it's imperative to restore the public's trust in the media to efficiently manage the pandemic. The second challenge is that a prolonged pandemic revealed some shortages of healthcare workers in some cities and provinces. Even if the number of beds for the COVID-19 patients is sufficient, it's been argued that not all the beds for the COVID-19 patients may be immediately operated, mainly because of lack of health professionals. So it's necessary to recruit and retain enough health manpower to avoid their burnout and to ensure their efforts compensated properly and timely. And last point is that acceptable risk should have been measured and agreed upon as early as possible to minimize unequal socioeconomic costs in addition to saving more lives. Stringency of social distancing could save lives of the patients, but must be accompanied by enormous socioeconomic costs. For example, it may have indirect negative effects on the health of the population through reduced income. So it's necessary to find out an optimal level of social distancing, not only to save as much lives as possible, but also to ensure livelihoods of the citizens. Okay, thank you very much for your attention. Speaker, over to you.
Thank you very much, Dr. Lee, for that presentation. I know for a fact that there's a lot of rich information in the case study beyond what you presented in the 15 minutes which we heard. A lot of it which covers not just response, but also innovations, the changes in regulations, but also lessons learned and challenges and the effect on, essential healthcare. So thank you very much. And we also encourage members of the audience to get in touch with us or the Korea team in case they want more further detail. I'll now introduce our second presenter for this morning. Dr. Tumurbat Byamba is one of the executive members of the Anagak Ukani Mergejel Nudin Academy. She's a medical doctor by training, and she's specialized in healthcare management and has worked at several management level positions of both government and non-government organizations in the health system of Mongolia. So without much further ado, I invite Dr. Tumurbat Byamba to make a presentation on Mongolia. Over to you.
Thank you, Vikram. Am I audible?
Yes, please. We can hear you loud and clear.
Good morning, everyone. I'm Tumurbat and a member of our research organization, Anagak Ukani Mergejel Nudin Academy. On behalf of our team, I would like to thank for providing this opportunity to share the case findings from Mongolia. Next slide, please. The presentation describes COVID-19 pandemic in Mongolia covering period between early of 2020 and end of October 21. So key responses and challenges as well as some highlights of the case study will be described. And current situation is much better now. So we tried to update some of the data accordingly. Next, please. Progress of COVID-19 epidemiology was somewhat different in Mongolia compared to many countries where we had the outbreak towards the end of 2020, and we can categorize 6 phases of infection with 4 major waves, as illustrated here. So, firstly, phase A is from January to November 2020, when we had few imported cases only. Then second phase is B, and it can be characterized by few cluster cases, and followed by a first wave of infection, which was peaking during mid-April, and then the second and third waves with more aggressive local transmissions, which spread all over the country due to increased movement of the people. Then the last phase of the, which is F period here, fourth wave, it was the spread of Omicron variant peaking in January of this year. General characteristics of affected was not much different compared to other countries. The incidence is higher in working age people between 25 to 39, with more cases among the men, while the mortality rate was higher among older people above 55 years, and more than half of them were women. And nearly 80% of all deaths occurred due to complications of existing comorbidities, especially cardiovascular disease, diabetes, and kidney diseases were the main leading causes. Deaths per 10,000 population has been maintained at lower levels throughout the pandemic in Mongolia, which is one of the remarkable difference. Next, please. Next slide, please. Now let's discuss some response measures implemented and share some of the key challenges. First of all, we had the existing response mechanism outlined by disaster preparedness law. We also had some experience in dealing with marmot plague and SARS, and also H1N1 influenza outbreaks. When COVID-19 progressed, the Parliament of Mongolia endorsed the temporary law to prevent, control, and reduce impact of COVID-19 pandemic. It was approved just after the pandemic in the end of April of 2020. This law allowed uninterrupted and flexible funding for preparedness and control measures. During the pandemic, the law was amended 6 times, and however, we faced challenges such as poor coordination and unclear role designation across the key players. Next, please. As a member state, the Mongolia maintained a certain degree of preparedness as a part of IHR capacity building at national level. State Emergency Commission chaired by Deputy Prime Minister. It is the national body that provides integrated coordination of preparedness and response activities. The current organizational structure on the COVID-19 response has been workable. However, there were some challenges. For instance, poor coordination and inconsistencies between decisions made by State Emergency Commission and Ulaanbaatar State Emergency Commission. Of course, I could not cover all of them. So next slide, please. Next slide, please. We implemented several key public health emergency response measures. The lockdowns were declared with the aims of preventing infection during the national holidays, and also Mongolia was marked as one of the countries which implemented the tightest restrictions around the world, and almost half of the participants interviewed for the case study, they considered that lockdown and consequent restrictive measures were not properly communicated throughout the system down to the ground level. And also few human rights violation cases related to lockdown were reported, along with recommendations for improvement. Although the contact tracing has been organized by a multi-sectoral team with support of ICT, However, there were challenges with several challenges with difficulty locating contacts and residential address, and also people were reluctant to share information due to fear of quarantine and communication difficulties with people with disabilities. Next, please. Health service delivery system is structured around primary and referral levels of the care. During the pandemic, all provider facilities were mobilized from November 2020, and as pandemic progressed, PHC providers have played important roles in management of asymptomatic, mild, and moderate cases of COVID infection. Overall burden of isolation, diagnosis, and treatment of COVID cases is shared by private facilities and hospitals, which was accounting for about 13% of the total COVID beds. Also, the quality of medicine, medical equipment, and PPEs supplied by private companies, they were greatly varied. Only the virology laboratory of NCCD was conducting PCR testing for COVID infection in January of 2020. Then the government has taken steps to increase number of the testing facilities, upgrading laboratories, and building capacity of human resource. Now the PCR is available in almost every geographical AMAX or provinces of Mongolia. And the changes of testing strategy to apply both PCR and rapid testing, it eased the testing load during the waves. Next slide, please. We faced several challenges in service delivery, which have been solved eventually. The PHC role was not clear in the beginning, and involvement was later than, and also private hospitals in the engagement remained unclear and neglected quite some time, and COVID care has been largely concentrated to the designated tertiary care institution, such as NCCD, and then later was distributed to other referral hospitals. As you see from this blue table, the decision to finance COVID-related services, including vaccination, testing, admission, and home management, with the payment per case for both public and private healthcare facilities, it was issued. This decision to fund allocation from health insurance fund contributed to increase the service provision and as well as the involvement of PHC and private health sector in response to COVID. Next, please. Ministry of Health issued quite wide range of guidelines to ensure the access and quality of essential services not to be compromised during the COVID pandemic. And respondents of the online questionnaire for case study, they expressed that PHC facilities and pharmacies were the main points of medical services. And only about 10% of the respondents, they say that they didn't experience any barriers for accessing healthcare during the pandemic. The remaining people had some kind of difficulties, mostly in process of getting appointment, getting diagnosis, and getting examined by the doctor. Also, interview respondents expressed that both service providers and patients, they felt dissatisfaction in continuity of essential services. Moreover, there is a doublet increase of maternal mortality in the first half of 2021. So there were there were disruptions, limitation in provision of essential medical services in both urban and rural areas. Next, please. In terms of human resource, resident doctors, graduate students, and retired personnel, they were mobilized for activities of surveillance, testing, and mitigation process. Legal environment was established, and some budget was allocated to address the socioeconomic issues of healthcare workers during the pandemic. However, according to our interview respondents, in the early period, there was shortcomings in the implementation of these benefits and the incentives, such as delays, underpayments, and lack of payment regulation for mobilized private hospital healthcare workers. And also there were issues of depression and burnout among healthcare personnel. Next, please. The government allocated several times additional funding to health sector in response to pandemic. For example, in the second half of the last year, the health system budget was amended by about 800 billion MNT. That is, government health budget increases by around 45%. Interview respondents, they were critical about accountability for public funds mobilized for COVID-19 as reporting, and also transparency of the donations by the individuals, private entities, and multilateral international organizations. Next, please. Currently, the vaccination rate reached quite high among the target population, who are above 12 years old, and children and adults, with almost 92% and 53% of them received full and booster doses respectively, thanks to the active campaign conducted by the government. Within the framework of the campaign, government provided incentives to speed up the vaccination for both population and service providers. For example, 50,000 MNT direct incentives to every person who received 2 doses of the vaccine from beginning of May 2021. As a result of this initiative, the coverage of the second dose was doubled within 2 months of time. Next, please. ICT application was made the response and mitigation activities easier, faster, accurate, and real time. We used the already existing tax system, VAT receipt scanning application, e-Parent. It was used to on QR code scanning for people's movement, registration, and contact tracing. Moreover, the education sector has been transferred into distance learning mode through TV lessons and online classes. Although there was some criticisms on distance learning for its efficiency and accessibility, but it became the inseparable part of the teaching and learning today in Mongolia. And government reform of digital revolution and launch of e-Mongolia platform, it enabled a supportive environment for adherence to the quarantine regimes by preventing people to pile up for getting public service during the lockdowns. Another upgrade is the horse system. In order to integrate system of the pandemic information flow and to decrease the information asymmetry, the separate systems of test results, vaccination, surveillance, and clinical management, they were all integrated into the name is the HOR, and into the HOR system, and it has a dashboard for decision makers such as the MOH and State Emergency Commission, and the other side they have as well as application for the people. Next, please. Next, please. From the case study, we would like to highlight these points. A new law was adopted, and which allowed more flexibility to mobilize funds and better regulation among the stakeholders. Also, increased funding for healthcare system and capacity is improved as well. NCCD's centralized role in clinical care, it provided a good lesson for further consideration of decentralization, and private sector involvement was increased. Of course, the government built up sufficient stock of vaccines and reached good vaccination coverage among the people. Next, please. Lesson learned. Lesson learned were importance of improving coordination and clarity of different stakeholders during public health emergencies, good planning of public health measures such as lockdown movement, regulation. Another key lesson is to maintain the provision of essential health services to to the people while combating with the pandemic and public health emergency situations. Moreover, continuously maintaining preparedness of organizational levels in terms of physical capacity and human resource is vital as well. We also learned that the better information communication play important role, especially in owning trust of the people, adherence to the measures, and the active participation. Next, please. Thank you very much for your kind attention. I tried to cover everything within 15 minutes. Thank you, but there are quite achievements and challenges we experienced during the pandemic. Thank you very much. Back to you, Vikram.
Thank you very much, Dr. Bamba. I know, again, the case study itself has much more detail, and covering all of that detail in 15 minutes is challenging. But thank you very much. And again, as we can see, I think there are many rich lessons to learn here, whether it be regulation, how engaging the private sector, also early ramp up of vaccination, use of innovation, and the important issue of human resources you bring up as well, in addition to many other issues. So thank you very much for that presentation. And again, I encourage the audience to get in touch with us or the Mongolian team in case they would like to learn further from their experience. So thank you very much to both our presenters for their engaging and thought-provoking presentations. We'll be now turning our attention to the panel discussion. I would like to welcome Aparna Somanathan, who will be moderating our panel today. Aparna Somanathan is the practice manager for the East Asia region for health, nutrition, and population at the World Bank. She's worked on many health system strengthening issues across several countries in Europe, in Asia, but also a lot in East Asia and the Pacific. She also has worked extensively on the implications of population aging on health financing and service delivery. So without much further ado, I call upon Aparna Somanathan as well, as the panel, for this panel discussion. Over to you, Aparna.
Thank you, Vikram, and good morning, everyone. Thank you for being with us today. We've had a great start to our first seminar with Dr. Lee and Dr. Diamba providing valuable experiences and lessons learned from Korea and Mongolia. Before we move on to the panel, I'd like to remind everyone, remind the live audience that the chat function on YouTube is active. Please do send through questions or comments that you have, and we'll try to address them live as time permits. We will now turn our attention to our panelists, who will reflect on the challenges and lessons learned on COVID-19 preparedness and response in their respective countries. We're honored to have three great speakers today. Sun-Man Kwon is the president of the Korea Health Industry Development Institute and a former professor and dean of the School of Public Health at Seoul National University. He has held visiting positions at the Harvard School of Public Health, London School of Economics, University of Toronto, University of Tokyo, Peking University, and the University of Bremen. He also served as the chief of the health sector group in the Asian Development Bank. We also have Ochirbat Batbayar, who is the advisor to the Minister of Health in Mongolia and a member of the Scientific Advisory Group of Experts on COVID-19 in Mongolia. Before joining the Ministry of Health, he served as an executive director of Transparency International in Mongolia to build anti-corruption coalitions with a focus on human rights. He also has experience in the field of medicine, leading the implementation of multiple programs for prevention and treatment of tuberculosis as a part of Mongolia's Health Initiative NGO, Mongolia TB Professionals Association, and the National Center for Communicable Diseases. And finally, we've got Gabriel Lung, who is the Dean of Medicine since 2013, the inaugural Helen and Francis Zimmern Professor in Population Health, and holds the chair of Public Health Medicine at the University of Hong Kong. He was Hong Kong's first Undersecretary for Food and Health and the fifth Director of the Chief Executive Office in Government. A specialist in public health medicine by training, Dr. Leung is one of the region's leading epidemiologists and global health experts. His research defines the epidemiology of 3 novel viral epidemics, namely SARS in 2013, H7N9 influenza in 2013, and most recently, COVID-19. In parallel, he leads tracking tens of thousands of lives to study the fundamental causes of non-communicable diseases. He led Hong Kong's government response against the 2009 influenza pandemic. He's been an official advisor to Hong Kong SAR and Chinese Central People's Governments, People Republics governments, as well as to numerous overseas jurisdictions and international agencies, including the WHO. So turning to you, Dr. Kwon, we'd like to ask about Korea's experience. And what has Korea's experience been of these new uncertainties? And how is the government of Korea adapting its country's COVID-19 response strategy to the pandemic as it continues to evolve? Over to you, Dr. Kwon.
Thanks a lot. Thank you for inviting me to this seminar, and good to see my old colleagues and good friends here. I'm currently working in the government agency, but it's always good to participate in this type of seminar and exchange ideas. Korea, as you know, recently experienced a huge, surge in the confirmed cases, but the number of fatality is still one of the lowest. So I think that, from a health economics or health policy perspective, I think mortality or fatality, it should be more important measure important than the number of confirmed cases. There are several factors behind these very high confirmed cases and low of fatality, which are obviously the nature of this COVID-19 recently. This variant of Omicron, as you know, is much lower severity. Another very important factor is that we have a very high rate of vaccinations. And also we had 2 years of experience of how to cope with this COVID-19 cases. So in that sense, although there is a recent hike of confirmed cases, but overall, I think Korea is one of the high-performing countries in terms of very low, one of the lowest mortality associated with COVID in the case. So in that case, I think there are 2 obviously cost-effective measures for the COVID-19. One is definitely, I think, face masks. Another one is vaccination. Maybe we can talk a bit more about social distancing, but as you know, there are huge social costs related with COVID-19, the social distancing. But face mask, at least face mask and vaccination are non-controversially, cost effective. Then what determines this face mask? I think it's a human behavioral factors, and many East Asian countries, especially like Japan, Korea, and China, almost all people wear face masks, and that it already become a part of this culture, because during the cold flu season, people wear face masks. During those very high air pollution time, people quite willing to wear face masks. So that is a bit simple. But another, the next one, vaccination, is a bit complicated, because as you know, in high-income countries, there are issues of trust and social capital that explains still a low, not very high vaccination, whereas in low-income countries, like funding issues, access issues. So we should work, we need this kind of global effort to increase this vaccination as well as face masks. And turn to the issue of social distancing, I think it's really very contextual, and the effectiveness is variable in different countries. context of Korea, we had a very tight social distancing, and it was effective in the control of those confirmed cases at the very early stage. But we should not, overlook the social cost related with the social distancing. It has a heavy impact on the small business and the daily workers. So maybe we need a good research and the cross-country comparisons to have a consensus on what is the kind of optimum degree or optimum timing of social distancing, taking into account the different contexts like labor market conditions, people's willingness to comply with something like that. So now I think from a Korea and also global context, there are several good important lessons. I'd like to discuss very briefly some of those issues. First, I'd like to mention the importance of agility or flexibility in policymaking, covering the legal systems, funding mechanisms, service delivery, or even patient triage systems. In the case of Mongolia, it is good to see that there's an 800% increase in budget during this pandemic crisis. So flexibility in the budgeting system is quite important. And I was also, it was good to listen to the comments from Mongolia about the transparency and accountability of this increased budget or increased funding pumped into the healthcare system during this pandemic. I think in the case of Korea, there are some issue that there is an incentive mechanism for private sector providers, hospitals, to encourage them to more actively participate in the patient triage system or diagnosis of this COVID-19 cases. And then there's an issue of whether the level or amount of financial incentive is enough or is too much. Okay. And also it's a very important lesson that in many countries, including Korea, Mongolia, the major increase in funding comes more from the government budget rather than from the contribution-based systems. So as a response to a pandemic, like a budget support or entitlement-based system is very important. I think it is a very important lesson for us in terms of healthcare financing. And also governance is important, coordination between central and local government, coordination between public and private sectors, and also coordination between different ministries. Because this is COVID-19 or pandemic. It's not simply a health crisis. I think it's a social crisis. So we need to mobilize the whole social resources to cope with this COVID-19. So it's the Ministry of Health, Ministry of Education, Ministry of Finance. They are all important. And also context seems also important. Like in Mongolia, there's mention that NCCD's role is too much, so overly concentrated. Whereas in Korea, I think central government, Korean CDC played a very important role, but still, the issue of coordination between central government and local government is very important, because school closures or details of social distancing are the responsibility of local government. So some local governments complied with the central government very well, but at the same time, the context of COVID-19 is different in different localities. In that case, what is the role of differential measures or even differential social distancing policy across different localities? In terms of service delivery, we all know that the mobilization of the private sector is the key, because we cannot rely on the public providers alone. However, in order to contract with private sector providers, in order to encourage them to actively participate, then we need to provide compensation. So then, as I mentioned earlier, whether the amount of incentive of financial compensation was too much or not, that can be a question of transparency and accountability. And I'd like to re-emphasize the importance of equity issues, because this COVID-19 hits hardest the poor and vulnerable population in our society, and also small business, self-employed or hit hard. And when the schools, when the classes are shut down and moved into a virtual education, virtual class, we can easily see that there's increasing gap, increasing inequity in terms of the performance of academics across children with different socioeconomic backgrounds. So how to overcome these inequity issues is a big challenge for us. We should never forget these equity issues. And also innovations in ICT, telemedicine is important in both in Korea, Mongolia, and other countries. And I think what is the future? I think there are unsolved kind of questions in terms of the future of our response or policy toward pandemic. Primary care, okay? Because I think that if we had a stronger primary care system, we could have responded better. Okay, so how to strengthen this primary system is important agenda for us. And the risk communication, both presenters mentioned the importance of risk communication, trust issues. It can, for example, have a very important impact on vaccination and face mask and personal hygiene measures. Finally, I think it's a dilemma, like a good research agenda for all of us, that what is the optimum social distancing, okay? Because if it is too strong, and also like a medical profession, they support the idea of a stronger social distancing, because medical profession only look at the confirmed cases and health perspective. But we all know that if you have a very tight social distancing, it can have a devastating impact on the socioeconomic system. But of course, if you have a higher mortality, it can have an impact on the economy as well. So what is the optimum social distancing policy as a response to a pandemic? We should work hard on this issue from now on, actually. Thanks a lot.
Thank you, Dr. Kwan. So turning back to Mongolia, Mr. Batbayar, how is Mongolia rethinking its response strategy given the new threats that are emerging and given where you find yourself now in terms of the reopening as well?
I would like first to give some more information about response. So Mongolia was maybe by mid 2020 were more had higher restriction, strong lockdown, but by July 2021, Mongolia was actually had a very free movement, and we already choose to live with virus and adapt a new life with the pandemic. So this actually gave us a better chance to tackle COVID. As mentioned, we had a strong vaccination program. Even though the country has issues with the economic situation, we had with support of our donors and with international partners, and even with support of World Bank, we managed to procure a better vaccine stock, and we had a better choice. We had Chinese-made vaccines, we had Russian-made vaccines, and we had Pfizer. And as a case study showed, we had very good vaccination coverage, and also very good booster coverage. By early July of 2020, same time with Israel and USA, we were already starting our the booster dose, and by early 2022, we already start our fourth dose. So this gives us very good a chance to fight successfully the COVID. Also, we have to mention that, as Dr. Sunman mentioned, that we had decentralized our healthcare service, and we had very strong and hard work of our primary healthcare workers. So most of family healthcare workers were largely involved instead of the CDC or Mongolia's National Center of Communicable Disease, and this gave us very good opportunity to fight pandemic successfully. And the government also provided free actually antiviral drugs and free vitamins for those patients through the family care units. So this means if somebody who tests positive, they were able to receive first day of after first positive results, the free package of the drugs. And secondly, we had also strong number of beds. So we not only hospitalized those who are in critically ill, we were able to hospitalize those who are actually likely to become critically ill. And our data shows that more than 25% of COVID patients were hospitalized. This gave us a very good chance to reduce number of the mortality. So even though our GDP is lower than Korea or Hong Kong or Japan, the mortality rate per million population actually almost same level as South Korea or Japan. So this shows that even countries with economic situation, the poor economic situation, can tackle issues better. So lessons learned, we learned a lot of lessons, and we see that as case study shows that we need to improve our legal environment. And Mongolia is actually about to have a new public health law, which will give the better opportunities to fight next pandemic. And because as case study shows that there were issues with the State Emergency Committee and role of the State Emergency Committee and the role of the Minister of Health and the role of the NCCT. So we plan to have organizations such as CDC of Korea or Taiwan, and we also plan to improve equity, inclusivity, and coherence of our healthcare system. And financing was also very crucial because most of our financing was government funded, and donors played huge role. And we also have to improve our surveillance and community involvement and healthcare system and coordination. So they are the main lessons we learned.
Thank you, Mr. Batbayar. So turning now to you, Dr. Leung, we've just heard about Mongolia and Korea's response strategies. Hong Kong has been very much in the spotlight, both in the early stages of the pandemic and more recently. Based on what you've heard from Mongolia and Korea, can you reflect a little on Hong Kong's experience?
Right, thanks very much, Aparna. And first, thank you to the bank for organizing this with the Korean government. It's a huge pleasure and privilege to be able to give a few reflections after having learned so much from those two keynotes from the two respective countries, as well as, of course, from my two predecessing panelists. Just let me sort of, first of all, reflect on two commonalities that I've heard from both presentations. The first is perhaps the most obvious, and that is the pervasive upgrading within a very short period of time of the ICT infrastructure to really bring the disease surveillance, monitoring, and response infrastructure into the age of big data. And it's not just restricted to, of course, South Korea or Mongolia, but in fact, you have seen it and witnessed it all around the world. And I think that it has brought about a step change, which we will see further improved post-COVID. And how precisely countries, as well as globally sharing, but also at the subnational level, make best use of the data to such an extent that perhaps we could look forward to a national disease surveillance service that perhaps would be as ubiquitous as a national weather service. Just as you look up the weather report every day before you go out, that day of us having similar data streams and analyses and predictive capabilities for disease surveillance, whether it's annual flu seasons or whether it's something that is as scary as the next pandemic, I think that that is something that we really need to think much more deeply about. The US has already started and has quite explicitly stated that that is the aim of this new data modeling unit within the US CDC, headed by my very good friend, Professor Mark Lipsitch, previously, or actually on secondment from the Harvard Chan School. So that's the first commonality. The second commonality that has struck me is the use of legal instruments in disease control, which you have seen to an unprecedented degree in COVID, mostly because countries needed to have additional legal instruments, whether it's by passage of a whole new main body of legislation or making provisions or regulations that is already allowed under the existing provisions. You have seen unprecedented use of legal means to invoke and then to enforce really quite draconian measures that we have not seen for perhaps half a century or even more in most parts of the world. And that has been built on the back of course, the last coronavirus pandemic, SARS-1, when in 2005, the IHR, or the International Health Regulations, which is an international treaty that was agreed to by 190 plus member states of the WHO. So is it time to revisit that international treaty? And if so, how might the world improve it? And therefore, through that international treaty revision, yet again, that would then percolate down to the national and, of course, the subnational levels subsequently. So those are the two main common threads that I've detected in both countries' presentations. The two different countries have very different sets of socioeconomic circumstances and contextual backgrounds. And therefore, they bring out very interesting and interestingly different perspectives. So if we sort of go to Mongolia first, I was quite struck by the liberal use of lockdowns, or in public health jargon, it's actually called cordon sanitaire. And of course, it all traces back to the second plague, which was during the 13th, 14th century in Europe. And that's when another port that was very similar to what Hong Kong is today, Venice, they imposed a 40-day quarantine of ships arriving into Venice, which was the major trading port. And that's in fact where we got the term quarantine from, because Old Italian 40 is actually quarantino. And so it's really almost unprecedented in centuries that you've seen the fairly liberal draconian measures, whether it's called social distancing or public health and social measures, to be more precise, which used to be called NPIs, or non-pharmaceutical interventions. And now the term lockdowns are thrown about quite liberally. But to me, and the Mongolian experience has taught us, along with others, that any kind of public health and social measure to mitigate disease, to protect health, is perennially in a three-way tug-of-war with two other almost orthogonal and sometimes opposing forces. The second one being, of course, economic preservation. And we've seen some of that with the trade-off, the explicit trade-off, that graph of GDP and deaths from the South Korean presentation. And the third force, which is sometimes, again, very orthogonal, is actually social acceptance of these draconian measures or public health and social measures and population well-being, including mental well-being and emotional well-being. And I think that the present Chinese experience, for example, the most recent news reports from Shanghai give a lot of room for reflection. So this three-way tug-of-war between health protection, economic preservation, and social acceptance and population well-being, I think, is what all governments have struggled with and continue to struggle with in the last 2.5 years. Now, let me then go to the other side of this coin, which is what I just alluded to earlier on about the explicit trade-off from Dr. Lee's presentation, where you actually plot deaths against GDP. And that is, by definition, underlying that is the utilitarian calculus of number of deaths per unit of change in GDP. So it's, however sort of distasteful it may sound, and I do not mean any disrespect, that's essentially what the value or a price tag actually is when you actually explicitly think about it and transparently think about it. So I actually applaud Dr. Lee for raising that for us to reflect on, because the utilitarian viewpoint is actually mostly shunned by traditional public health. Public health schools don't like that particular approach, except when they teach about cost effectiveness studies. And in fact, in the US, that term is no longer and has not been accepted by the government, and in fact has been banned from all official literature for a very, very long time now. So value of care is the new and acceptable term, but it actually refers to the same thing. Rather, a lot of public health has been predicated on the duty of care, on the rights perspective, that very positive liberal perspective. Or if you actually take the Chinese approach, which is actually now very unique in many parts of the world, and that is that communitarian approach, where it is invoked to justify some of the very, very intense measures that are now being taken in Shanghai to protect, really, the rest of the country. Now, the next thing that I would like to sort of compare and perhaps contrast between the two presentations in the two countries is the whole idea of triage of care. So the escalation or de-escalation or the distribution or allocation of care according to need, and how health financing systems and health delivery systems that are pre-existing would give you the results that you might have been able to observe during COVID, despite the fact that the basic concept and approach to health financing are actually very similar between the two countries. So we heard from South Korea that very good triage has been able to deal with surge capacity issues. such that overwhelmed ICUs and overwhelmed hospitals, those scenes did not happen, or at least not to any substantial degree. And part of that was because they took the copays away, which made it much more easy to seek and to provide care without the traditional gatekeeping instrument of a copay against a background of a national social insurance system. Whereas we've heard from Mongolia that primary healthcare outlets and provision at the beginning had not been optimized, and therefore actually led to suboptimal outcomes, at least for the first half of the Omicron experience. And of course, here in Hong Kong, we have never had a robust, publicly provided or even funded primary care system. And indeed, some of the scenes that we have all witnessed very, very painfully in February and early March of overflowing public emergency rooms was a direct result of this background. The next thing that I would like to perhaps reflect on are two issues that are common throughout the world. One is, how do we count deaths? Whether you're looking at IHME data or whether you're looking at Oxford Our World in data, or the Johns Hopkins data dashboard, or your own national data dashboard, you will see deaths associated with COVID. But actually, underlying those numbers are very different definitions that vary vastly from country to country. Whether they are defined, perhaps typified or exemplified by, say, the UK approach, where all patients who died within 30 days of a COVID diagnosis, by whatever means, is defined as a COVID death, which is very liberal and very inclusive, versus the other end of the spectrum, which is a very clear, deliberate delineation, almost death certificate based, and therefore very much subjective, of trying to tease out death with COVID or death of COVID, only including death of COVID into the official case count. And then you have the WHO definition, which is somewhere in the middle, which basically says within a certain period of time, it remains a diagnosis of exclusion. So if there were competing causes that are convincing, then it will not count as a COVID death, but otherwise everything else should count as a COVID death. And I think that that actually needs much more treatment and scrutiny so as to make numbers more comparable before we reformulate policies post-COVID based on those death counts. And finally, just let me reflect on the collateral damage, which has not been really properly analyzed or studied. The collateral damage that has been very deep and very inequitably distributed everywhere you've looked, in the few places that had looked. And that's sometimes captured in some of the excess deaths or excess hospital use data. But I think that we are nowhere near to proper scrutiny of non-COVID health decrements that are directly or indirectly a result of the pandemic. We are already seeing some devastating effects in TB control or loss of TB control. And of course, you will see the ravages of the EPI coverage, particularly in LMICs and particularly in LICs. And you will see that very, very soon, if you haven't already seen it yet. So I think I'll just conclude with that, and very much looking forward to learning still further from the rest of the discussion. Thank you, Aparna.
Thank you, Gabriel, and thanks very much to the panelists. Just on the collateral damage issue, Gabriel, the World Bank is doing quite a bit of analysis on this using whatever household survey data we have access to, as well as administrative data. So hopefully in a few months, there will be some analysis of this. And you're absolutely right on TD and EPI, it's not looking good at all. Anyway, we are over time, but I would like to at least pose one of the questions that we received on the YouTube channel. And that is on, and Gabriel, you touched quite a bit on the history of quarantine and so on. But the question was, are there any historical parallels that can be learned, or lessons that can be learned from the 1918-22 pandemic? Did we underestimate the duration of COVID-19 and the ensuing variants, given that the pandemic of 1918 lasted 4 years? So maybe a minute each to each of the panelists. Any thoughts on that, learning from the 1918 pandemic?
Should I give it a go first, Aparna? I think that most epidemiologists actually warned, using the 1918, 1919, 1920 pandemic as example, way back in 2020, when a lot of the Western world were hit from March onwards in 2020. And after that initial wave started to dissipate, people started to relax again. And a lot of us sort of said, look, the so-called 1918 pandemic, the first wave was not nearly as bad as actually the second wave. But most countries did not act accordingly. So I think that if there is anything that we've learned or not learned from COVID, is how COVID has been so predictable. And unfortunately for us and the world, the advice and the predictive advice specifically were mostly not heeded because of that three-way tug of war, I suspect, that I talked about earlier on. Unfortunately, those predicted adverse outcomes actually all panned out until vaccines came along about 12 to 15 months ago. So going forward, I'm more optimistic, but I think that COVID, the bug, have quite a few more surprises for us yet.
Thank you. Mr. Batbayar or Salman, any thoughts on that? Mr. Batbayar, you might be muted.
Yes, so there is of course parallel. It's both big pandemic with 100 years difference, and we see that we were able to actually have vaccines this time compared to 100 years ago when it was 1918 pandemic, and technology give us better advance. This is the difference, and we see that as Dr. Gabriel said, of course, there's some more variants to come, but we are better prepared. And a lot of countries were actually able to learn from each other's tactics, strategy. I know some countries made wrong decisions. And so this gives us a better advantage. Even though there is a parallel similarity, we are in much better situation, I believe.
Thank you. And I'd like to say a big thank you to our panelists for very thoughtful, very reflective comments, both on your own countries and more globally. So at this stage, I'd like to hand back to Vikram. Thank you.
Thanks, Aparna. And I would really like to thank all the panelists again for their very reflective comments, as well as, not just for this pandemic, but actually going back into history. And I think there are many lessons, again, that we need to learn from this pandemic, not just for the current pandemic, but any future pandemics as well. So I think it's upon to us to move the knowledge in that direction. I would now like to welcome Jason Alford, the Special Representative and Country Manager of the World Bank Group Korea office, for his closing remarks. Over to you, Jason.
Thank you, Vikram. We're over time, so I'll be brief. Firstly, I'd like to, like you, thank all the speakers and panelists today for the very interesting discussion. I'd especially like to thank my colleague, Director Shin from the Ministry of Economy and Finance, for co-hosting this event with us today. I'm, of course, the representative of the World Bank in the Republic of Korea, and our office here in Korea is committed to facilitating knowledge exchange between Korea and our other member countries. One thing that stood out to me today from the presentations and discussions is that in COVID response, one size, of course, will not fit all. The institutional and cultural context in Mongolia is different from that in Korea, and indeed every country is different. But there are also commonalities of experience that we can leverage, and research such as we've seen presented today helps us to identify those areas of commonality, and the discussion helps us to identify those. I think our other member countries are interested in hearing of Korea's experience in combining traditional health sector investments with new digital tools and revisions to legislative and regulatory frameworks to maintain patient confidentiality, maintain confidence in the system. That's all of interest. The broader social and fiscal response is also of interest. And also for the World Bank, of course, issues of potential inequity are very interesting and something that we can learn from Korea and take to our other countries. Let me finish by thanking you, Vikram, and your team for supporting today's discussion. Thank you to everyone in the audience who's joined us today and listened. I look forward to seeing you all at the next webinar in this series, where we will hear from the experiences of Fiji, Malaysia, and Vietnam. Thank you all. Back to you, Vikram.
Thank you very much, Jason, for capping this session off. I would like to thank everyone for their participation today and your engagement. I know we've run a little out of time, and yet we've not given full justice to this discussion, but we hope to keep this conversation going. You will also find a link in the chat box to the website that'll take you for all the materials that were shown today. We also have a short feedback survey, so we would really appreciate if you could actually take that. And then we look forward to seeing you in the webinar series for the other countries as well. So thank you very much all for participating today. Apologies for being a little bit over time. Thank you very much.